3 of our 2021 happy hour session. Today we're going to be looking at kind of what I've chosen to term the good, the bad, and the ugly. We'll be looking at a selection of cutaneous tumors with obviously kind of a focus on adnexal tumors, with the exception of the first 3 cases, which is going to be dedicated to a different differential, mainly clonal proliferations within the epidermis. I want to remind everybody that we're going to be doing another Dermpath core exam review course on February 13th. A couple of weeks ahead of time, we'll send out a slide deck and some questions. These will be a little bit different from the last review session that we ran in the fall. And also next week, we're very privileged to have Dr. Oswald, Sandra Oswald, who's the chief of dermatology at the University of Texas in San Antonio, also boarded in dermatopathology, hosting our happy hour session. She's a wonderful speaker. We've had her as a guest before, and I know that's a session you guys will definitely want to tune into. So I've got my chat up here. If you have any questions, please feel free to use the chat. And then if any questions arise that or anything you think of after the session runs, please feel free to send us an email at education@sagisdx.com. We'll try and put that in the chat as well too. Or you can email me directly at tdavis@sagisdx.com. Or you can reach me on my cell phone, 210-416-4815. Please feel free to call or text. So with that being said, we will go ahead and get started. So our first case is a shade biopsy. This was actually from the trunk. And we zoom in a little bit. We can see that there's not, too terribly much of an inflammatory infiltrating the dermis. But if we look at the epidermis, we can see that it is kind of gently papillated and moderately acanthotic. As we move to higher power, we begin to see that the cornified layer is thickened in many areas by basket weave hyperkeratosis, maybe a little bit of perikeratosis in a few areas. The epidermis, again, is somewhat acanthotic. And I think even at low magnification, we'll kind of zoom in here, we can appreciate that there are these kind of nested clones of keratinocytes within the epidermis. And these clonal islands are composed of very uniform keratinocytes. These keratinocytes have round to oval nuclei. If you take a look, there's really no appreciable nuclear pleomorphism, no mitotic figures, really no apoptotic cells, and notably an absence of any ducts within these structures. There are a few small horn cysts present within the epidermis, and this is a classic clonal seborrheic keratosis. Now, the differential diagnosis in a lesion like this always includes an eccrine poroma, which you'll remember is in the acrosporoma group of adnexal tumors. It's composed of acrosyringeal epithelia, and a Hidroacanthoma simplex really is best thought of as a poroma confined to the epidermis. And in those lesions, you get nested aggregates of very uniform keratinocytes, somewhat similar to these, but within the central portion of the aggregates and really across the neoplasm, you should be able to clearly identify ducts with the eosinophilic cuticle. And so in their absence, it is difficult to make the diagnosis of a poroma. Another point that we'll make when we look at a few of our subsequent cases is that with poromas, they tend to have and the acrosyringeal tumors in general, the eccrine acrosporomas, they tend to have a characteristic stroma that's edematous and vascular. which is absent here. Now, another key item in the differential here would be early evolving squamous cell carcinoma in situ, or Bowen's disease. And that can begin sometimes with clonal proliferations of keratinocytes, nested aggregates of keratinocytes in the epidermis, which on blush can look like these. However, one notable difference, there's atypia of those keratinocytes. So the keratinocytic nuclei will be hyperchromatic, pleomorphic. You should be able to identify mitotic figures. And usually in most areas, you can see full thickness keratinocytic atypia. So this is a real nice example of a clonal seborrheic keratosis. And on a board exam, you know, if they were to show you this, they're always going to include Hidroacanthoma simplex and Bowen's disease, or squamous in situ, in the differential, which is why I wanted to discuss that differential. Okay, let's go ahead and move on to slide 2. Let me flip the slide here. And we've got a trisected shave biopsy specimen. This was actually from distal extremity, from the forearm. And you can see right away, before I move in, that this has a very similar architectural pattern to the first slide that we looked at. The cornified layer looks a little thickened. The epidermis is gently papillated and mildly acanthonic. Now, in the papillary dermis, in this instance, there's a little bit more robust of an inflammatory infiltrate. We can see these small dark staining cells here, which are lymphocytes. And if we look in the epidermis, I think even more easy to spot here, it's obvious that we've got these clones or nested aggregates of epidermal keratinocytes within the epidermis. Notice there's sparing of the basal layer here. So these nested aggregates are above the basal layer. Some of them are kind of even compressing the basal layer. We know these are keratinocytes, say, rather than melanocytes, because as we move to higher power, we can see intercellular bridges here between these cells. And unlike the case we just looked at, I mean, there is striking nuclear pleomorphism of the keratinocytes comprising these aggregates. The nuclei are pleomorphic, that is, they're variable in size and shape. Some are hyperchromatic. And you don't have to look in very long before you start picking up abnormal mitotic figures. This almost looks like a chromosome spread here. In addition, there's more pronounced parakeratosis within the stratum corneum. And even some of these parakeratotic cells in the stratum corneum are a little bit pleomorphic and hyperchromatic. And I'm going to go to another section, because if we look over at the edge, first of all, there's striking ciliary elastosis in the dermis. And second of all, in areas you can see full thickness keratinocytic atypia here, which tells you this is squamous in situ or Bowen's disease, rather than a clonal seborrheic keratosis. One might also consider the possibility of a porocarcinoma, but again, there's no evidence of duct formation within the central portion of these nested aggregates. One could also think about the possibility perhaps of melanoma, because these cells are kind of nested. But again, melanoma begins at the dermal-epidermal junction. And there are no nested aggregates of atypical keratinocytes here at the dermal-epidermal junction. Okay, so this is Bowen's disease, squamous cell carcinoma in situ. That's kind of beginning with clonal aggregates of cells within the epidermis. And some of these may actually be derived from acrosyringeal or acrotracheal keratinocytes, as both pass through the epidermis. Okay, let's go ahead and move on to slide 3. And again, we're focusing in the first few cases on proliferations within the epidermis. Again, kind of very similar architectural pattern here. We have somewhat of a dome-shaped papule. The epidermis is papillated. And in this case, a little bit more hyperplastic. As we move to higher power, we see there's really not much of an inflammatory infiltrate. There are a few foci of purulent scale crust within the epidermis. And of the 3 cases we've looked at by far, this clearly has the largest clones present within the epidermis. And you can see these are greatly expanding and thickening the epidermis. Right here, you can see a very sharp cutoff between the epidermal keratinocytes, which are right here, and the cells comprising this particular proliferation right here. Now, as we zoom into higher power, we can see that this is a very monotonous proliferation of cells. These cells have a cuboidal appearance, round to oval nuclei. There's virtually no nuclear pleomorphism or atypia, virtually no mitotic figures. These cells have a moderate amount of eosinophilic cytoplasm. And if we look within some of the aggregates, I think it was more obvious in some of these sections than others, there are zones in which there's clear evidence of duct formation. So we've got these ductal structures here in the epidermis. This is even a better one right here that I've circled. I'll go ahead and, well, I can't go to higher power, but you can detect a faint eosinophilic cuticle, a centrally located duct. And so within this neoplasm, we have clearly identifiable ducts. Also, note that this epithelial proliferation confined to the epidermis has this distinctive loose edematous stroma with a lot of vessels. And this is a stroma that's very characteristic of the acrosyringeal tumors. And so what we have here is a acrosyringeal tumor confined to the epidermis, and this is a Hidroacanthoma simplex. If there was extension of these aggregates with epidermal attachment into the reticular dermis, that is below the level of the superficial vascular plexus, then we would call this a poroma. And of course, if there was no epidermal connection, but we had smaller aggregates or similar sized aggregates of similar appearing epithelium confined to the dermis, we call it a dermal duct tumor. And so the designations and the transition from one to the other is somewhat arbitrary, and there can be overlap, but this is a poroma. So again, I wanted to show you a classic Hidroacanthoma simplex. I didn't mean poroma. Hidroacanthoma simplex, kind of a clonal Bowens and a clonal seborrheic keratosis, because they're all 3 going to show up on the pick list. And they might even, in some instances, include melanoma, especially if we have kind of a nested squamous in situ, like the one we just looked at. Okay, let's go ahead and move on to slide 4. Slide 4 is a little bit different. I'm going to tilt the slide a little. And what we have here is a trisected shade biopsy. And one can see that this lesion is pretty papillated. You know, it's a little bit exoendophytic, and we have projections extending above the level of the epidermis here. We've got a lot of scale crust. And even at low power, we're beginning to see a little bit of necrosis here of cells. Again, notice the presence of a very loose edematous stroma with vessels. And again, when I see this type of stroma, I begin to be a little suspect of acrosyringeal or ecrine differentiation within a tumor. If we zoom in and look at the cells comprising this epithelial neoplasm, we begin to see quite a bit of nuclear atypia. These nuclei are large, and there's quite a bit of pleomorphism. Many are hyperchromatic. If you look hard enough, you can see a few apoptotic cells. This nucleus is becoming dark, and the cytoplasm becoming quite pink. It's on its way out. There are a few mitotic figures scattered within this neoplasm. And so these are features suggesting that this is a malignant epithelial neoplasm. And when we look within the tumor itself, we see several easily identifiable ductal structures, suggesting that this is a carcinoma with ductal differentiation. And what we have here is a porocarcinoma. There can be a lot of overlap, I think, histologically between lesions of squamous cell carcinoma in-situ and porocarcinomas. But what you should see in a porocarcinoma is the presence of clearly identifiable ducts. In addition, this edematous vascular stroma can be another clue to the diagnosis of a ductal tumor. And clearly here, the necrosis and the cytologic atypia indicate that this is a malignant neoplasm. Excuse me. Okay, we'll go ahead and move on to slide 5. Okay. Slide 5, I really don't need to tilt this because I can't, there's no way these have been cut and embedded or placed in such a way on the slide that they're all different angles. Okay, we have a small punch biopsy here. Obviously, what really catches your eye is all the red down in the dermis, and that's nothing more than procedural hemorrhage. I think it's always a good idea to assess location. And this is a little bit of a different location in that we see ductal structures here and glandular structures, but we really don't see follicular units. In addition, there's an awful lot of smooth muscle present within the dermis. I mean, numerous small smooth muscle bundles. We've got dilated vessels here and kind of an edematous stroma, suggesting the likelihood of a special site. Now there's a granular layer, so we know we're not on a mucosal surface, and this was actually from the genital region. The epidermis is markedly acanthotic. The cornified layer is thickened by compact orthokeratosis, and there's a little bit of hypergranulosis. And as we move to higher power, we begin to see these collections of very pagetoid appearing cells within the epidermis. And when we say a cell is pagetoid, we mean that it has abundant pale staining cytoplasm. So you can see these cells are large, they have abundant pale staining cytoplasm, and they also have enlarged nuclei. And there's quite a bit of nuclear pleomorphism here. These nuclei are somewhat variable in size and shape. And you can see that these pagetoid cells are present above the dermal epidermal junction. Some of them are solitary, others are forming small nested aggregates, but you can see that they compress the basal layer here. We can even better appreciate it. Let me get my pencil out over here so you can see these basal layers here. These cells in the basal layer, the basilar keratinocytes, are compressed by these pagetoid cells, which really show a predilection to extend and evolve and take over much of the spinous layer here. Some of them are actually even up in the stratum corneum. And so, you know, when we see this type of pattern, an acanthotic epidermis peppered with pagetoid cells, then really the key differentials, the top 3 differentials, would include melanoma. They would include a pagetoid expression of Bowen's disease, or they would include extramammary Paget's disease, which really can be next to impossible to distinguish from one another without benefit of knowing exactly the clinical presentation and where the lesions arise. So let's see what we can do on H&E, see if we can eliminate one or any of those differential considerations without the use of immunohistochemistry. Well, as I pointed out, melanoma tends to involve the dermal epidermal junction. And while the cells of melanoma in situ and invasive melanoma may have a pagetoid appearance, again, they arise at the dermal epidermal junction. They will not compress the basal layer like that. And so the fact that we don't have compression of the basal layer would make melanoma a much less likely consideration. Okay. What about Paget's disease? Let's first discuss Bowen's disease. What about Bowen's disease? Well, as we saw in the last example, Bowen's disease is usually characterized by atypia of epidermal keratinocytes. And if we look between the pagetoid cells here, we can see that the epidermal keratinocytes are maturing normal in a normal fashion. There's no significant cytologic atypia of these epidermal keratinocytes. Their nuclei are not particularly hyperchromatic or pleomorphic, and there are no areas where there's full thickness atypia of the epidermis, which will make the diagnosis of Bowen's disease or squamous cell carcinoma in situ much less likely. So given the features suggestive of genital skin and the histologic appearance, my money here would be on extramammary Paget's, or if this were from the nipple, on Paget's disease. Of course, we're going to confirm with immunohistochemistry in the setting of Paget's or extramammary Paget's. These cells, the pagetoid cells, would stain strongly with cytokeratin 7 and epithelial membrane antigen, also frequently with CEA, although that's a less specific stain. These cells would be negative for the melanocytic markers, S100 protein, MART1, or SOX10. So this is an example of extramammary Paget's disease. And Paget's disease will look virtually identical to this. Okay. Let's go ahead and move on to slide 6. We've got a shave biopsy here. Quadrisected shave. You know, in the first blush, as we kind of move in and take a look at this lesion, there's some sebaceous glands and hair follicles. So, you know, I don't think this is face, but we may be on the trunk near the face or perhaps up near the neck. And it's hard to say, you know, at this power, whether this is inflammatory or neoplastic. There's a dense nodular blue infiltrate in the skin, which at this power is kind of suggestive of a lymphocytic infiltrate. And given the density of the infiltrate, you know, we might think about things like lupus erythematosus, because it looks like it's extending deeper into the dermis, or at least to the base of the biopsy specimen, or even something like lymphoma. As we move in, though, we can see that the redi are kind of elongated and a little bit hyperpigmented, and that would be a little unusual for lupus. Lupus tends to efface the dermal epidermal junction. And as we move to higher power, we begin to see a lot of melanophages in the dermis, and, you know, looking along the dermal epidermal junction, we begin to see these nested aggregates here. This is a little out of focus and pixelating, but we can see nested aggregates of melanocytes at the dermal epidermal junction. And as we move along the dermal epidermal junction, we can see that these melanocytes, arranged as variably sized nests and confluent solitary units, are also extending into the overlying epidermis. So we've got a junctional melanocytic proliferation here on sun-damaged skin, characterized by confluence of somewhat atypical melanocytes. Some of these have nuclei that are hyperchromatic and pleomorphic, along an effaced dermal epidermal junction with upward scatter. And so this is like screaming melanoma in situ. And indeed, as a rule of thumb, if you've got a broad melanocytic lesion, or for that matter, really a junctional melanocytic lesion on sun-damaged skin, really a good starting point is melanoma in situ. You should have to really convince yourself. There should be compelling evidence that a junctional melanocytic proliferation on sun damaged skin is not melanoma in situ. That's obviously kind of an oversimplification, but if you use that as your starting point, you're much less likely to miss subtle melanoma in situ. And of course, we could throw a Melan-A or a SOX10 or S100 on this and demonstrate the confluence of melanocytes. Another kind of perplexing finding here, though, is the presence of these lymphoid aggregates, or these nodular collections of lymphocytes here. And obviously, they could be a harbinger of desmoplastic melanoma, but there's no real spindle cells here in the dermis. This was kind of an interesting case because if we focus in on the epidermis, right at the edge of the biopsy specimen, I'll let this kind of catch up. It's a little pixelated here. Hopefully I won't have to reload it. But in this particular area, and I may have to go ahead and reload the slide. I think I will, because this is an important feature that I want to point out. So, and it's really kind of an explanation of why we've got this lymphocytic infiltrate. If we look at this area of the epidermis, we can see we've got a small intraepidermal vesicle. And this intraepidermal vesicle has formed in part as the consequence of necrosis and acantholysis. So these cells are rounding up and separating from their neighbors. And go ahead and look in the epidermis, and you can see a multinucleated epidermal keratinocyte, at least one. Here's another one up here. And look at the nuclei of these keratinocytes. There's peripheral condensation of the nucleoplasm. These have a washed out or a steel gray color, and the cells are becoming ballooned. And this is absolutely pathognomonic viral cytopathic change characteristic of a herpesvirus infection. And so what we have here is, this was actually zoster. You can use immunohistochemical stains to help you differentiate simplex from zoster, but clinically, the patient had zoster, actually came in for the zoster, and the dermatologist noticed a very atypical pigmented lesion in the distribution of the zoster. So we have melanoma in situ here in conjunction with herpes zoster. And one of the caveats here is obviously never be pleased with one diagnosis. So if you look at sections and you made what you think is a definitive diagnosis, always take a little extra time to look to see if there's any associated diagnosis that you may be missing. So I thought this was kind of a cool case. Okay, let's go ahead and move on to slide 7. We'll go ahead and close out our last group of slides with kind of a few adnexal tumors that we don't tend to see quite so often. Now, obviously, we've got a big blue ball here in the dermis, and it's blue because these cells, what you're seeing with the blue is the nucleus. So these cells have large nuclei and probably not so much cytoplasm. It seems to be fairly sharply circumscribed here. Might have even shelled out. I think this one did come in as a cyst. There's no epidermis. This appears to be confined to the dermis. But if you looked at the dermis, you could see there was a lot of skeletal muscle in the dermis here. And so skeletal muscle inserts into the dermis on the face, so the muscles of mimetic expression. So we're probably on the face, and indeed, this was actually from the eyelid. So we have this epithelial neoplasm here, and it's composed of these nodules present within the dermis. Some are solid, and others are a little bit more cystic. And as we move to higher power, we can see kind of these elongated branching tubules here, which kind of are suggestive again of a glandular neoplasm. We tend to see elongated branching tubules in apocrine neoplasms. And, there may even be a little hint of decapitation secretion here. And we can see that in some areas, there's mucin in the center of some of these cystic areas. And in some areas, there was actually even a little mucin within the cytoplasm of these cells. Now, as we move to higher power, we can see that these cells have a moderate amount of eosinophilic cytoplasm. There's not too much nuclear pleomorphism. They're relatively uniform. The nuclei are round to oval in shape, and they've got this very, very fine chromatin pattern. And when we see this chromatin pattern, it's kind of a feature we tend to see in tumors showing neuroendocrine differentiation. And this tumor is actually positive for neuroendocrine markers, synaptophysin and chromogranin. And this particular lesion is an endocrine-mucin producing sweat duct or sweat gland carcinoma. It shows a predilection for the eyelid. This is a very characteristic appearance, and it falls within the spectrum of and tends to arise within an apocrine hydrocystoma. And so what happens is, one can get an apocrine hydrocystoma, and some of them will develop complex infoldings and become increasingly cellular. And we'll give you this picture. These, in turn, tend to accumulate over time massive quantities of mucin within the tumor aggregates. And a good percentage of these, if left untreated, will progress into mucinous carcinoma of the skin. And so this particular tumor runs along the continuum of apocrine hydrocystoma, cystadenoma, this particular tumor, endocrine-mucin producing sweat duct carcinoma, and then mucinous carcinoma. These are very low-grade neoplasms. They will recur if not removed in their entirety, but almost never, if ever, metastasize. You just want to remove them because they'll persist. And again, the patients, if these are untreated, they will progress and develop into mucinous carcinomas. So the likelihood of getting this on a board exam is slim. It's only been described in the last 10 or 15 years, but this is an endocrine-mucin producing sweat duct or sweat gland carcinoma. And I noticed in the latest edition of Elston, he's got an example of this in the chapter on adnexal tumors. Okay, we'll move on to another bit of a rare bird. This is a neoplasm you don't want to see very often. This is a bisected punch biopsy from acral skin. One can see that the cornified layer is markedly thickened by compact orthokeratosis. The epidermis is irregularly hyperplastic, and within the deep dermis, extending into the subcutaneous tissue, we have a very sharply circumscribed epithelial neoplasm, kind of is surrounded by this fibrous capsule. And it's got solid areas and cystic areas, very blue. So that tells you again that these cells probably have a pretty high nuclear to cytoplasmic ratio. And if we move to higher power, we can clearly see there are ducts and tubules here. So we know we're dealing with a glandular tumor. Now, if we look here, we can see, we begin to appreciate that these glands are tightly packed in here, almost back to back. This is a little thick, but there's some nuclear pleomorphism here. And let's go ahead and move over to the other piece. An area that's cut not so quickly. And you can see, again, these are very tightly packed glandular structures, back to back. There's some nuclear hyperchromatism and pleomorphism. There are mitotic figures present within this lesion. And we've got these papillary projections extending into a cystic space. If we were to do a Ki67 or MIB1 proliferation marker on this, this would have an elevated proliferation rate. And really, this lesion, I think, most closely resembles a hidradenoma papilliferum, right? In that we've got a blue ball in the dermis. It's kind of complex, it's got complex enfoldings and papillary projections. It lacks the plasma cells that we see with a syringofibroadenoma adenoma papilliferum, but we know that hidradenoma papilliferums tend to occur in apical-rich areas. So, the genitalia, like I said, I've seen them in the ear canal, but we wouldn't expect to see one on the digit. And this is an example of an aggressive digital papillary adenocarcinoma, also known as a papillary digital carcinoma. This is a very potentially aggressive neoplasm. And the bad thing about it is it can occur in younger individuals. I've seen at least 2 or 3 cases in teenagers and in young adults in their 20s. And I've seen at least one that metastasized to the lungs and killed the patients. And the treacherous thing about these neoplasms is that they don't always show a lot of cytologic atypia. In one of the instances that I saw, it was signed out as a benign adnexal tumor with eccrine differentiation. And that was the one where the patient ended up getting a big recurrence and by that time had pulmonary metastasis. Here you can see a mitotic figure, but you don't have to see a lot of nuclear pleomorphism. And one of the take-home points here is that really all digital papillary tumors with glandular differentiation like this should be considered to be malignant. You want to make sure you get them off, and you want to make sure that the patient is evaluated for metastatic disease. So aggressive digital papillary adenoma. When these were first described, they were described as having either a benign variant, an aggressive digital papillary adenoma, or the ones that were cytologically atypical were called aggressive digital papillary adenocarcinoma. A number of years ago now, someone went and looked retrospectively at a large number of these tumors, and there were several cases where the benign appearing variants actually had metastatic disease. So there's no longer a benign form of this tumor recognized. So aggressive digital papillary adenocarcinoma or papillary digital carcinoma. And again, any papillary digital lesion should be considered to be carcinoma. Okay, let's go ahead and move on to 9. We've just got 4 more here. This is a punch biopsy from the digits, from the distal extremity. I've got digits on the brain. And this was from the leg. You can see we've got a lot of nodular angioplasia. And what's striking about this particular lesion is, we've got these elongated anastomosing strands of ductal epithelium extending down into the dermis. These are hyperplastic acrosyringeal elements, and some of them are interconnected, forming this anastomosing network. And this is syringofibroadenomatosis, which can be a reactive process. In this case, we talk about reactive syringofibroadenomatosis. They're just kind of reactive hyperplastic eccrine ductal strands. But these can also become clonal, and there is a syringofibroadenoma, which is the neoplastic counterpart of this reactive change. They aren't too commonly encountered. They tend to occur on the lower extremities, and they've been reported in hydrotic ectodermal dysplasia and occasionally in SHOP syndrome. So again, anytime you see these elongated ductal structures derived from acrosyringeal and ductal epithelium, which form these strands which anastomose, you want to think syringofibroadenoma or syringofibroadenomatosis. And whether it's reactive or neoplastic depends upon the clinical setting. And this change can occur in a variety of inflammatory and unrelated neoplastic conditions. Okay. We'll go ahead and move on to slide 10. Slide 10, we had a bisected punch biopsy. This piece kind of fragmented and was mal-embedded. And one can see in this punch biopsy, this was from the face, we've got a neoplasm present within the dermis and extending into the subcutaneous tissue. If we look at this portion of the specimen, it seems to be fairly sharply marginated. It's partially sampled, so we can't assess all architectural features. But if we move to higher power, we can see we've got several small uniform ductal elements embedded in a chondromyxoid stroma, okay? And these ductal elements are lined by uniform cells. They have a moderate amount of pink staining cytoplasm, a little bit of an open chromatin pattern, but the nuclei are certainly uniform. They're not pleomorphic. There's no mitotic figures, and they're evenly spaced. And again, they're embedded within a chondromyxoid stroma. Now notice we don't have any elongated branching tubules here. And this is a chondroid syringoma, or mixed tumor of the skin. In this case, this is one characterized by ductal epithelium. And this particular variant of a mixed tumor is regarded by some as being an equine variant of a mixed tumor. In my experience, mixed tumors composed of these small ductal elements are not near as common as mixed tumors with elongated branching tubules. But this is an example of a mixed tumor with small ductal lumina. Okay, we'll go ahead and move on to slide 11. Slide 11 is another biopsy from acral skin. See a markedly thickened stratum corneum, absent follicular structures. This is a little bit fragmented. And within the deep dermis, we can see portions of this neoplasm that fell out. It's probably extending somewhat into the underlying subcutaneous tissue. And what we've got here are nests, cords, strands, and kind of sheets of cells embedded within a very sclerotic stroma, somewhat hyalinized here. If we go down and take a look at the cells, we can see that they're fairly uniform. Some have round nuclei, some have oval nuclei. Some of the cells have slightly spindle-shaped nuclei. And if we look at our other piece of tissue, we can see that some of the cells have a distinctive plasmacytoid appearance. What do we mean by that? Well, think about plasma cells. Plasma cells tend to have abundant pink cytoplasm, right? The nuclei is a little bit displaced and characterized by perinuclear clearing. And so these cells, which are the same as these, have a little bit more of a plasmacytoid appearance. In addition, you can see that rather than being hyalinized, this stroma over here is extremely myxoid, okay? And this bears striking similarity to the stroma that we saw with our mixed tumor, right? But what's lacking here in the presence of these neoplastic aggregates are ductal elements or tubular structures, okay? And this is a neoplasm that was long recognized in other organ systems before it was recognized in the skin. This particular tumor will stain positive for S100 protein. It'll stain positive for cytokeratins, P63, and also smooth muscle actin and calponin. And this is a tumor which is known as a myoepithelioma. Now, surrounding sweat ducts and sweat glands, there's usually a discontinuous layer of myoepithelial cells, okay? And so this is closely related to the mixed tumors that we looked at. In a mixed tumor, one gets a preponderance of epithelial cells proliferating. And so we get the ducts and lumina. And the cells at the periphery, the myoepithelial cells, which contract and help get the sweat secretions out of the gland, are usually not very pronounced. But at the other end of the spectrum, which is what we've got here, there's a proliferation of myoepithelial elements, and the glandular and ductal structures do not comprise so much of the neoplasm. So this is much less commonly encountered than a classic mixed tumor, but the stroma and arrangement of the cells is very similar. And if you see a uniform proliferation of round, oval, spindled, and plasmacytoid cells in a neoplasm or comprising a neoplasm with a stroma like a mixed tumor, you want to think about the possibility of a cutaneous myoepithelioma. There is a malignant counterpart of this. One can get a myoepithelial carcinoma as well, but those are not very commonly encountered. And this tumor can occur in young individuals, and they're frequently seen distal extremities. But the immunohistochemical profile is very characteristic. And again, this is a tumor that will express both S100 protein, frequently P63 or other cytokeratins, and SMA. So I just wanted to make sure that you were aware of this tumor. And then again, in the most recent edition of Elston, he's included this in his discussion of adnexal tumors. And we'll go ahead and end with something which is a little more pedestrian that you're likely to see. This is a kind of my Garden of Eden case. And one can see we've got a broad shade biopsy that's been kind of bred low down its length. The surface of the specimen is definitely papillated. The epidermis is very hyperplastic. And there are very large sebaceous lobules here, which open up, many of them, directly onto the skin surface. So that's one thing that we've got going on here. In addition, emanating from the undersurface of the epidermis and extending into the dermis, among other things, we have these epithelial aggregates that are composed of uniform cells, uniform keratinocytes. They have somewhat clear staining cytoplasm here, kind of suggesting outer root sheath differentiation. And if we look at the periphery of some of these aggregates, we can see that these cells have kind of a cuboidal to columnar appearance. They're a little bit more vertically oriented, and they're sitting on a thin basal lamina. Centrally, some of the aggregates are more irregular in shape and embedded within a somewhat sclerotic stroma. And so what we have here is a desmoplastic trichomoma occurring within a nevus sebaceus with a papillomatosis and enlarged sebaceous glands. But we don't have to stop there, because if we look at this bottom piece, we can also see that we've got several small trichoblastomas also originating from the undersurface of the epidermis. These are composed of very basaloid appearing cells. There's peripheral palisading, and these particular trichoblastomas are replete with papillary mesenchymal bodies, these aggregates of fibroblast that are intimately associated with these basaloid aggregates. So nevus sebaceous with trichoblastoma, desmoplastic trichoepithelioma right up here, and the coup de grace, we actually have down in our bottom piece, a syringocystadenoma papilliferum. So you can see transition from stratified squamous epithelium here to ductal epithelium, okay? We've got 2 to 3 layers here lining these ductal structures. And within the stroma, between these anastomosing ductal structures, we've got tons of plasma cells. So this really is a nevus sebaceous that's a Garden of Eden with a variety of adnexal tumors arising within this nevus sebaceous or organoid hamartoma. So that was kind of a fun case to end on. And again, wanted to show you some things that were a little bit more unusual this week. If you guys have any questions, please feel free to reach out. And if you have any suggestions for future topics, please be sure to let me know. Thanks so much.